When are gastrostomy tubes necessary for congenital feeding issues? Feeding challenges are common in children with congenital muscular dystrophy, and understanding when a gastrostomy tube might be needed can help families prepare and plan for care. Congenital muscular dystrophy is a group of genetic conditions characterized by muscle weakness present from birth or early infancy. As these muscles weaken over time, especially those involved in chewing, swallowing, and sucking, feeding can become increasingly difficult. This can lead to poor weight gain, dehydration, and increased risk of respiratory infections from food or liquids entering the lungs. In many cases, children with congenital muscular dystrophy experience difficulty chewing and delayed swallowing reflexes. Their mouth and throat muscles may not work effectively, making it hard to safely swallow food and liquids. As muscle weakness progresses, these problems tend to worsen, leading to longer feeding times and increased fatigue during meals. For example, in some types like Maricin-deficient congenital muscular dystrophy, children often show abnormal swallowing patterns, with food pooling in the throat and a higher chance of aspiration, which can cause pneumonia or other respiratory issues. When oral feeding no longer provides enough nutrition or becomes unsafe due to aspiration risks, healthcare teams consider a gastrostomy tube. This tube provides direct access to the stomach, allowing nutrition, fluids, and medications to be delivered safely without the need for oral intake. It helps ensure children receive adequate calories and hydration, which are vital for growth and overall health. While short-term feeding support might involve a nasogastric tube inserted through the nose, this is usually temporary. For ongoing needs, a gastrostomy or jejunostomy tube is preferred because they are more comfortable and less likely to cause complications over time. Deciding to place a gastrostomy tube involves a team of specialists, including pediatric gastroenterologists, dietitians, speech and swallowing therapists, and surgeons. They evaluate how severe the feeding difficulties are, the child's nutritional status, and the risk of aspiration. They also consider respiratory function because weak respiratory muscles can increase the risk of complications. The goal is to improve nutrition, reduce the chance of lung infections, and make feeding less stressful for both the child and family. In some forms of congenital muscular dystrophy, such as congenital myotonic dystrophy type 1, feeding problems are especially common in infancy due to weak sucking muscles. In these cases, a gastrostomy tube might be used temporarily until the child can develop enough oral strength for safe feeding. For others, it may be a long-term solution if muscle weakness continues to interfere with safe swallowing. Proper management of a gastrostomy involves careful planning of feeding volumes and schedules to prevent issues like acid reflux or slow stomach emptying, which are common in muscular dystrophy. Sometimes additional procedures like a Nissen fundoplication are performed to prevent reflux, but this depends on individual risk factors and is decided by the medical team. In summary, a gastrostomy tube becomes necessary when muscle weakness from congenital muscular dystrophy causes unsafe swallowing, poor nutrition, or recurrent lung infections due to aspiration. It is a tool to help ensure children get the nutrition they need safely and comfortably, improving their overall health and quality of life. Every decision is personalized, made with input from a team of healthcare professionals to best meet each child's unique needs. Always consult with your child's medical team for guidance tailored to your child's specific situation.